Thank you for the invitation to speak at the meeting on opportunities for the digital development of primary care, telemedicine for the future of Europe, on the session on pulse wave analysis-based telemedicine. You might be wondering why an obstetrician is talking about preeclampsia in this session, and that's fundamentally because we have got the etiology of preeclampsia wrong for over 100 years. It's now very apparent from recent publications that preeclampsia is indeed a cardiovascular disease, a disease of supply and demand. The maternal cardiovascular system supplies the hugely demanding uteroplacental circulation. And if there is a mismatch between supply and demand, then there is underperfusion of the placenta, and the subsequent consequences are the development of either fetal growth restriction, preeclampsia, or both. It's important to understand that the predisposing factors for preeclampsia are the same factors that predispose to cardiovascular disease, such as maternal age, obesity, diabetes, hypertension, and kidney disease. And then in pregnancy, there are some unique features that increase cardiovascular load, such as macrosomia, gestational diabetes, twin pregnancy, prolonged pregnancy. And if either of these groups of factors or both occur, then there is a mismatch between supply and demand, and preeclampsia develops. There is really strong evidence on the basis of our recent COVID pandemic that this is indeed the case. Cardiovascular factors predispose to preeclampsia, and cardiovascular risk factors predispose to development of COVID. What we now know is that getting COVID infection, especially in the last third of pregnancy, increases the risk of preeclampsia some 5 to 6-fold. And not because of the pre-existing cardiovascular risk factors, but because COVID infection itself is related to myocardial injury. And myocardial injury and underperfusion of the placenta sets off the cascade that we now recognize as preeclampsia. So what is the role of pulse wave analysis and cardiovascular assessments in preeclampsia? First is that of screening. The established screening method in most countries is to take a routine history and ask for cardiovascular risk factors in early pregnancy, and very sort of really an old-fashioned way of grouping women to high and low risk categories. And that does not allow personalized care. It's now apparent from the New England Journal publication from the Fetal Medicine Foundation group that the best screening test is the combined preeclampsia screening test in the first trimester that includes medical history. These are risk factors such as age, height, weight, obesity, cardiovascular risk factors. The measurement of placental growth factor, PLGF. It is a hormone that's produced by the placenta, but also in non-pregnancy and children. And this hormone's principal role is to improve or to create cardiovascular remodeling to deal with an excess demand. And then also in this first trimester screening test is blood pressure and uterine artery Doppler. The use of this test has a 75% detection rate for preeclampsia with a 10% false positive rate. That is 4 times better than the current use of checklist-based approach. What it is important to understand here is that uterine Doppler was always undertaken on the pretext that it was reflecting what was happening in the placenta. But now the latest studies show that using either ophthalmic artery Doppler or radial artery Doppler is equally good to uterine artery Doppler in the screening of first trimester preeclampsia risk. And what these have all in common, risk factors, PLGF, blood pressure, and all of these Doppler characteristics, are that they're all cardiovascular risk assessments. So they are all assessing the cardiovascular system and not the placenta. But what is the purpose of doing early pregnancy screening? And that's because we can modify outcome. Using this screening test, followed up by the selective use of low-dose aspirin and increased fetal monitoring, there are now a series of publications showing that we can reduce overall preeclampsia rates by 25%, and specifically preterm preeclampsia rates, the most dangerous condition, by 75%. We reduce small for gestation age birth at term by 40%. And this is the latest data. Perinatal death in a cohort screened using the first trimester algorithm, 35% reduction, with a 3-fold reduction in ethnic minority group perinatal death from 3 times higher than white population to equivalent to the white population in the FMF screen cohort. So early screening, effective monitoring and treatment is able to reduce health disparity in your population, not just for non-white women, but for example, sociodemographically deprived women, women of higher weight, higher age, etc. Now, what are the cardiovascular findings in preeclampsia? There is now a series of publications. I'm just going to select the latest one. This is a systematic review of all of the echocardiographic studies in preeclampsia to show that whatever study you look at, out of these 20, there is a consistent reduction in global longitudinal strain and strain rate in women when they develop preeclampsia. That means to say that the heart is uniformly under stress and strain in this condition we know and recognize as preeclampsia. Is birth a cure for preeclampsia? Unfortunately, it seems that that is not the case. We have been saying that for 100 years. But in reality, this study that we recently published, where we did echocardiographic assessments before and in the same women after, a few days after delivery, showed that all of the standard criteria and indices we use to assess maternal cardiovascular function did not improve with the birth of the baby and the reduction in the cardiovascular load that was there throughout pregnancy. So is it just that we didn't give enough time, or is there a persistent defect of the maternal cardiovascular system in preeclampsia? So we set out to look and see, well, how quickly does maternal hypertension resolve? So first of all, we did a systematic review. And in this systematic review involving about 1,200 women, it was evident that the chronic hypertension risk at 1 to 2 years of age in women who developed preeclampsia was about 9-fold higher than in women who did not have preeclampsia. So these women were 9 times more likely to develop preeclampsia. That is a significant increase in risk. However, what this systematic review doesn't tell us is the time course of that risk. Was it early on in 1 year, at 1 year or 2 years? And certainly doesn't tell us the absolute risk. What is the magnitude of the risk after preeclampsia? Well, this was a collaboration with a Danish group, the Serum Statins Institute, where with over 1 million women, we looked at the prescription of antihypertensives to both non-preeclamptic and preeclamptic women. And what you can see here in this thin blue line is the rate of chronic hypertension in women who were 40 years old after a normotensive pregnancy. And you can see that about 10% of these women develop chronic hypertension within 10 years of giving birth after a normotensive pregnancy. If women had preeclampsia, this is hypertensive disorder of pregnancy, this is 20-year-old women at 10 years postpartum had higher rates of chronic hypertension compared to 40-year-old women. What that tells us is that the occurrence of preeclampsia has an effect of almost cardiovascular aging by 20 years, and that women who are 20 years old who develop preeclampsia have a 1 in 10 risk of developing chronic hypertension by the time they're 30 years of age. So does preeclampsia increase just the risk of chronic hypertension? That appears not to be this case. In this collaboration with a group from Maastricht of over 1,100 women, they split these women into early onset preeclampsia with a small baby, early onset preeclampsia with a normal sized baby, and late onset preeclampsia with a small baby. This is progressively more severe preeclampsia as we go from this group on the right, late onset at term, to early onset with a small baby. And what we saw is that the presence of central obesity, high blood pressure, diabetes, hyperlipidemia increased progressively the more severe the woman's preeclampsia during the pregnancy. And that there was really evidence of metabolic syndrome, not just chronic hypertension, after the development of preeclampsia within the first 10 years. And it's not just metabolic syndrome. There is now overwhelming evidence that preeclampsia, and especially preterm preeclampsia, predisposes not only to chronic hypertension, to heart failure and coronary artery disease, but also to the long-term development of cerebrovascular disease. It is important to understand that there is a specific temporal trend in these occurrences, that hypertension occurs within the first 2 years, as we've told you, an 8-9-fold increase in risk. Chronic kidney disease occurs somewhere within the first 5 to 10 years, and then subsequently direct myocardial dysfunction, followed finally by cerebrovascular disease. So there is definitely cardiovascular morbidity after preeclampsia, and it occurs much earlier and much more frequently than we have previously assumed. So in running up and summarizing this, the women at highest risk of preeclampsia are the ones with the poorest cardiovascular function beforehand. If you have predisposing factors such as height and weight and diabetes for cardiovascular disease, then you have the same predisposition to preeclampsia. Women with the worst cardiovascular dysfunction in early pregnancy are the ones that are most likely to develop it. And that's the FMF screening algorithm assesses maternal cardiovascular function, and those with the worst function are the ones that are likely to develop it. Screening is important because we can modify and reduce the incidence of adverse pregnancy outcomes. Women who develop preeclampsia have consistently abnormal cardiovascular function at the time that they develop the disease. And finally, cardiovascular dysfunction appears to persist postpartum, even if women are normotensive. Can we improve postpartum maternal cardiovascular health? Indeed, it seems we can. This is a series of studies, the pickup and the SNAP-HT and the long-term outcome of SNAP-HT. This was a study where in the first 6 months after birth, women were randomized between self-monitoring using home blood pressure monitoring or routine care where midwives and GPs occasionally measure their blood pressure as per the routine national protocol. And what was evident at 1 year postpartum was that women who had had self-monitoring and very close self-titration of antihypertensive medication had much lower blood pressures by 7 millimeters of mercury in diastolic blood pressure than women who had routine care. This was a follow-up study 3 to 4 years later of the same group of women to show that 3 to 4 years later, after cessation of the home blood pressure monitoring, the women who had lower blood pressures continued to have lower blood pressures several years later. What this tells us is that close monitoring postpartum with cardiovascular monitoring and tight control of blood pressure has long-lasting beneficial effects to the maternal cardiovascular system. And that follows this Navid Sattar's hypothesis of cardiovascular disease in pregnancy. If one has good cardiovascular health, pregnancy perturbs that, but perhaps not to the degree where you develop disease or disorder. And sometimes several years later, in your 70s and 80s, you may develop cardiovascular disease. Some women have perturbations of the cardiovascular system that create a condition of preeclampsia or growth restriction during the pregnancy with subsequent recovery. And again, during the next pregnancy with subsequent recovery. And his hypothesis is that there is much earlier onset of cardiovascular disease as the cardiovascular system deteriorates. And therefore, this time period here offers a window of opportunity, a window of treatment where one can perhaps ameliorate this deterioration in maternal cardiovascular function. What we have shown is that that window of opportunity occurs much earlier and is much more prevalent than we have previously assumed. So there is a real dire need for early treatment, early monitoring, and early control of these disorders and diseases. So, in conclusion, we can screen far more effectively for preeclampsia now, as long as we acknowledge the cardiovascular predispositions and use tests that assess maternal cardiovascular system pregnancy. There is also potential, which I didn't cover because of time, for use of cardiovascular monitoring and peripheral waveform monitoring in triage of women who present with borderline blood pressure in pregnancy. This is a major health cost in most economies and would offer advantages for women to be able to be monitored remotely from home. Finally, most importantly, postpartum cardiovascular disorders occur more frequently and far more earlier, and the use of blood pressure or peripheral waveform monitoring offers the opportunity to screen, monitor, treat, and ameliorate long-term risks in these women. The postpartum period presents an opportunity to screen for and prevent adverse cardiovascular outcomes in women. The PregnaScan tool, which I'm familiar with but have not researched in a great deal, offers an incredible opportunity to actually try and deliver that in a remote fashion, in a practical and pragmatic fashion for women in a home setting, rather than to increase visits to hospitals or clinics at a time when they're trying to look after a baby. Is this important? Absolutely it is. The American Heart Association now for several years has been promoting Go Red. Go Red for Women is a specific program which acknowledges that heart disease is the #1 killer of women, not cancer. Women and their hearts remain understudied, far less studied than in men. Women also remain undertreated, with their morbidity and mortality being 30% higher than for men for the same disorders. And women are not small men. There is a prevalence or a predisposition for cardiologists to treat women as if they're small women. Actually, their physiology and their pathology is different, and it deserves to be studied. Thank you very much for your attention. I hope you enjoy the rest of the conference.